Okay, this begins a series of videos which is an approach to acute kidney injury. So before we even talk about acute kidney injury, there's a few introductory concepts that I want to go over first. Here's one definition for acute kidney injury, and this was put together by a group called the Aiken Criteria. And so you can see it's a combination of a change in the serum creatinine and a change in the urine output. And you can see that they sort of have some broad categories of risk, injury, and failure based on the severity of the rise in serum creatinine, okay, and also a decline in the urine output. And these are time-based, so you can see a decline in urine over 6 hours, 12 hours, and then 24 hours, or anuria times 12 hours is how they stratify things. Now you can see at the bottom the Aiken Criteria. This is the Acute Kidney Injury Network, and so they have different stages, you know, stage 1, stage 2, stage 3, and sort of the similar criteria, you know, a change in creatinine, a change in the urine output. So you can see how they stratify things, and it's very similar. And my main point, you know, is not that these should be memorized, and clinicians certainly don't speak in these terms. These were put together by research groups so that when they're doing research on acute kidney injury, they could have a standardized definition. But the main thing I want you to know is that AKI is a combination of, you know, change in the serum creatinine as well as a decline in the urine output. So rise in serum creatinine plus a decline in urine output together pretty much defines acute kidney injury, and you can see sort of how research groups have at least stratified the severity of acute kidney injury based on the changes in each of these variables. Okay, since we spent some time talking about creatinine and acute kidney injury, we should at least discuss the kinetics of creatinine. So creatinine comes from muscle, so this is a muscle belly right here, and about 1 to 2% of creatine is actually converted to creatinine per day. So creatinine comes from our muscle, and so if you think about the more muscle you have, the more creatinine you're going to make per day. Less muscle mass equals less creatinine. So every day we make some creatinine, and it is filtered freely by the glomerulus. So a lot of it is filtered by the glomerulus, but some of it is also secreted by the tubule. So in the proximal tubule, there's active secretion, and probably in normal people it's about 15%, but it could be more in someone with chronic kidney disease. So creatinine is mostly filtered. There's a little bit of secretion, and this is how it's handled by the kidney. So in this sense, we use creatinine as an endogenous marker of GFR. So we do have a number of other methods, like exogenous markers of GFR, and a perfect substance would be something that's only filtered and neither reabsorbed nor secreted. But we tend to use creatinine because you know, production is typically pretty stable from day to day as long as your muscle mass remains stable. So creatinine production remains stable over time, and then we can assume that the excretion is dependent on functions of the kidney, especially GFR. But as we know, you know, tubular secretion can change; it can go up or down. And the bottom line is that the amount of creatinine excretion, the amount that ends up in the urine, does exceed the amount filtered. But since it's mostly filtered, we do use it as a crude approximate for the GFR because you know, testing is pretty ubiquitous. It's relatively cheap, and so this is why it's used so often. So when considering the diagnosis of acute kidney injury, remember you need an increase in the serum creatinine as well as a decrease in the urine output. And so you know, let's consider a situation where the serum creatinine has gone up, but the GFR actually remain quite stable. And so this can happen if medication is co-administered that actually blocks tubular secretion of creatinine. And so there's a couple of drugs that do this. So trimethoprim, so a component of Bactrim, can do this. Dronedarone, which is an antiarrhythmic used in atrial fibrillation, and then also cimetidine, which is you know, not really used anymore due to all the drug interactions, but it's an older H2 receptor blocker used to treat reflux. Also consider a situation where the urine output has declined, but the GFR remains stable, and so this can happen especially in the post-operative setting. Remember, there could be some fluid losses and you know, just the sort of shock and trauma of undergoing an operation. Sometimes there's a normal decline in urine output, and that doesn't necessarily mean that there's been acute kidney injury. So you need both a rise in the serum creatinine and the drop in the urine output to really make the definition of acute kidney injury. So keep these things in mind, especially when you're seeing patients with a rise in the creatinine or something else and you're thinking about acute kidney injury. So while we're on the subject, I want you to appreciate the relationship between the serum creatinine and the GFR. And so the main takeaway is that it is a non-linear relationship between creatinine and GFR. And so this graph really pertains to CKD patients with chronic kidney disease. So we measured serum creatinines in patients and then did nuclear GFR studies. So used a exogenous tracer that's only filtered and not secreted or reabsorbed to actually measure the GFR, just to correlate how serum creatinine varies according to the GFR. As you can see, it's nonlinear, and so this graph is sort of just a representation. It's slightly different based on gender and race, but I'm just sort of showing one to make it easy. Okay, while we're on the subject, I want to make sure you understand the nonlinear relationship between serum creatinine and GFR. And so this graph really pertains to CKD patients. And really what was done was that they had their GFRs actually measured with an exogenous marker, not something endogenous like creatinine, an exogenous marker that actually measured the GFR, and then made a graph based on what their serum creatinine was. And as you can see, it's an inverse relationship and it's nonlinear, and that the lower the serum creatinine, the higher the GFR. But it's worth noting that, let's consider a patient with a baseline serum creatinine of 0.6. If that number doubled right to 1.2, it still looks quite low, but that could reflect rather a very large change in the GFR. So going from 0.6 to 1.2, that's a doubling of the serum creatinine, and in some electronic medical record systems, that may not flag as abnormal, but it really is a large change. On the other end of the spectrum, let's say at the low end of GFR, you can see that serum creatinines actually fluctuate to a greater amount, and so we see a lot of patients with advanced kidney disease, and at the lower GFR spectrum, the creatinine can vary up and down a good amount. But to define acute kidney injury, we care more about the magnitude of change of serum creatinine. So a doubling of the creatinine at this range could represent a large change in GFR. So one main takeaway is that in chronic kidney disease, or even normal state without kidney disease, serum creatinine is in a steady state condition where the amount of creatinine being produced every day equals the amount being excreted every day. And this is why you can measure the serum creatinine every day for a week in a row, and you'll get just about the same value. Of course, there's a little bit of variation due to error in the testing. But the main takeaway here is that for acute kidney injury, you're in a non-steady state situation where the amount of creatinine being produced, remember, let's assume it's constant based on constant muscle mass from day to day, that creatinine production exceeds the excretion. Okay, so in this setting, you could assume that the excretion decreased due to a change in the GFR, and that was the underlying problem. And of course, that's after you exclude inhibition of tubular secretion, as we mentioned in the slide before. So this graph showing the nonlinear relationship, this graph was done in patients with CKD, but it's important to consider this as well in terms of what the patient's, quote, baseline creatinine is. And then in order to think about AKI, think about their baseline creatinine, and then look at the current creatinine, and then look at daily changes in the creatinine. That helps you determine whether they have AKI or not. Okay, so just to illustrate some of these principles, let's consider, a 58-year-old male who's in the hospital, and today his serum creatinine is 5.5 milligrams per deciliter right here. And so, just knowing that much information, what can we say about the patient? And, I don't know if I could really say too much about the patient with just one value. And I know that I've seen a lot of providers try and make a lot of decisions about a patient with just seeing one creatinine, but the way a nephrologist thinks, at least, is was the creatinine doing over time, okay? And so with the serum creatinine of 5.5, you're right, this could represent acute kidney injury. Let's say the day before it was 4.5, and the day before that it was 3.5, right? And so, sure, if the serum creatinine is doing this on a day-to-day basis, that indicates, no GFR. If it's rising that much, every day, okay? 2, 3, 4, 5.5, so that's a problem. Alternatively, the patient could have chronic kidney disease, and maybe the serum creatinine is pretty much stable. Let's say it's 5.3 in clinic, it's 5.5 today, and then when this patient's seen a month later, it's 5.4 or something. So this patient could just have chronic kidney disease. Okay. Alternatively, what if this patient was just transplanted, just had a kidney transplant? Maybe the creatinine's on the way down. Okay. Maybe the patient came in, the creatinine somewhere up here in the 8 range, it's 5.5 today, it's 3 something tomorrow, and by the time we see them in clinic, it's 1.8 milligrams per deciliter. So it could be improving. Alternatively, it could be a patient who's on hemodialysis, and so the creatinine is dialyzed off with dialysis, and so the day after dialysis, it's lower than it is normally. But what's happening is that with dialysis, it's up and down, and so 5.5 could just be sort of a trough level of creatinine, and then after a couple of days, it builds back up again, and the patient gets dialysis, and it's back down. And so any of these things could be occurring, and so it's worth considering what the creatinine is doing over time, because it makes the difference whether it's going up every day, going down every day, stable day to day, or sort of up and down when it reflects something like a hemodialysis treatment. So here are some main takeaway points. The absolute value of the serum creatinine does not reflect GFR if it's not in steady state. Okay. The change in the serum creatinine in the urine output is most helpful for diagnosing acute kidney injury. And if the serum creatinine is rising, more than 1 milligram per deciliter per day, assume that the GFR is essentially nil. It's less than 10. It's nothing, and that's how you can dose your drugs. One important thing is that make sure you're able to differentiate between true acute kidney injury, so a change in the creatinine and a drop in urine output that's occurred over a number of days, versus newly recognized chronic kidney disease, which can happen. And so just keep that in the back of your mind as you're talking to the patient, looking at labs, and doing a good history and physical. So you've probably learned about acute kidney injury before, and you probably learned it in a way that described it in terms of pre-renal causes, intrinsic renal causes, and post-renal causes. And the language used to describe this is in terms of where the AKI is located, or where the reason is. And so I do find this very helpful, but I have come up with a slightly modified version of how I think about acute kidney injury. So the way I'm going to organize subsequent videos is AKI organized by why rather than where. And so I like to tie everything into the underlying mechanism, because I think when you organize things this way, it allows you to sort of make faster connections and think through things more readily in the moment with clinical encounters. So my 3 categories is: number 1, global perfusion of the kidney. Number 2, sort of what's happening on the local level in terms of glomerular filtration in the kidney, and then also all the ways intrinsic renal disease can affect kidney function. So the next set of videos will go through AKI based on this organizational structure. Supported by the William and Sandra Bennett Clinical Scholars Program and the American Society of Nephrology.